Just to remind you, the clinical notes here are cervical cancer for staging, and we're presented with an MRI which demonstrates a number of different sequences. Now, in this particular case, contrast was administered. That is not a requirement for a standard cervical cancer staging study, but we've administered in this scenario. So I'm going to just take you through an approach of how I look at these sorts of studies, and then also give you an update on the FIGO staging for cervical cancer. So typically I will start with the Sagittal T2 high resolution image that we can see here. This is a great place to start with really all of your pelvic MRI studies, because it just gives you a really great overview of what's going on in the pelvis. It gives you an idea of the orientation and the position of the uterus, as well as gives you a sense of what else is going on in the pouch of Douglas and then in the bladder. And here we can see, if I just pause here, we can see the uterus is axial in orientation. We've got a good amount of distension of the bladder, not too overfilled, not too underfilled. And you can see here that in this case, we've administered some vaginal gel. Centered in the cervix is this abnormality, which is of intermediate T2 signal intensity and basically replaces the whole of the normal cervix. So this is the cancer that's known, and we can see that this lesion is really large. Now, when it comes to FIGO staging, size matters for stage 1. So stage 1 disease is about cancer localized to the cervix. And for this particular stage, the magical number is 2 centimeters. Tumours that are 2 centimetres or less means that there could be consideration of fertility-sparing surgery, whereas those tumours which are greater than 2 centimetres will often mean a hysterectomy would be the planned course of action, or chemoradiotherapy, depending on the further staging. So you want to have a look carefully and give a size measurement and report that. If the lesion is confined to the cervix, the distance of the superior margin to the internal os is also important clinical information that the surgeons will want to know, because it helps them plan the kind of surgery that they're going to embark upon. Now, in this case, I would then go to the Axial T2, which is really an axial oblique scan through the cervix, with the idea of creating the cervix into a series of donuts. And the reason we do this is because it really helps us stage for parametrial invasion. So for stage 2 disease, we are really interested in disease that is outside of the cervix. And this might be stage 2A, which is invasion of the upper 2/3 of the vagina, or stage 2B, which is invasion into the surrounding parametrial fat. And this is an important staging difference, because it helps the clinicians plan with respect to whether the patient may go on to hysterectomy or may be a consideration for radiotherapy. Now, the thing to say about this particular stage is we sometimes on MR have a tendency to overstage. So just be mindful of that when you're looking. Trying to assess for upper vaginal invasion can be really tricky. And that's why I personally like to give vaginal gel, because it just helps to distend that upper cervix and try and determine whether cervical tumour is actually invading the upper third of the vagina. But the other thing that is really important for staging is assessing that T2 dark deep cervical stromal ring. So a normal cervix will be T2 dark, and you should see multiple rings as you scan through on the axial oblique plane. If we have a look at this case, I really am struggling to show you any normal deep cervical stromal tissue. Perhaps this part here. So this part here would be a more normal appearance, and we can see here tumour basically replacing all of the cervix. So we're dealing with a minimum stage 2 disease. If the deep cervical stromal ring is completely intact, that has a very high negative predictive value for the presence of parametrial invasion. If you see a little bit of disruption, be careful, particularly in the post-biopsy setting, because we can have a tendency to overstage parametrial invasion when we see minimal disruption. But in this case, you'll agree with me that there is no question here that this has got replacement of the normal deep cervical stromal ring. And also we can see evidence, particularly here on the left, of parametrial invasion into surrounding fat. So this tumour is minimum stage 2B. To assess for stage 3, we're talking about then extension inferiorly into the lower third of the vagina or up against the pelvic side wall. They talk about on MR tumour invasion up to within 5 millimetres of the pelvic side wall. So we can see here that this tumour does not appear to extend over to the pelvic side wall. And if we go back to our sagittal imaging, we can see that this tumour is very much in the upper 2/3. So confirming that we in fact are dealing with a locally aggressive stage 2 disease. The other thing to check for stage 3 is looking for hydronephrosis or hydroureter. And we can see here the left ureter and here the right ureter, and both of those ureters have no evidence of hydroureter or dilatation. So confirming that this is in fact very much a stage 2B tumour, not a stage 3. The other important part that has changed in the FIGO staging of 2018 is the addition of abdominopelvic lymph nodes into the staging criteria. This is stage 3C. Prior to 2018, lymph node involvement was not included as part of the staging, but it is now a component. And it can be broadly classified into stage 3C1, which is basically lymph nodes in a pelvic distribution, versus stage 3C2, which is para-aortic lymphadenopathy. And don't forget, you can use the DWI sequence to help you detect lymph nodes, but you can't really use it to help you distinguish whether the lymph nodes are benign or malignant. So let's review the DWI sequence here. So here we can see the DWI high B value sequence, and we can see here the primary tumour is very high signal on this DWI sequence and is confirmed on the ADC map to be low, so corresponding to abnormal restricted diffusion. Just be mindful that if there's a lot of blood product, that can disrupt your interpretation of the DWI sequence. So always review the T1-weighted sequences to see whether there's any blood products, which there aren't if you have a review now. If we use this sequence and scroll up in this way, we can see along the left pelvic side wall here a lymph node. If we correspond that to the T2-weighted sequences, that actually corresponds to this lesion here, which you'll agree with me is large. It's fairly homogeneous in signal intensity, but I would argue looks similar to tumour signal. We don't see any speculations, but to my mind, this is a suspicious lymph node. And if we go to the corresponding PET scan, which is recommended in higher staging locally advanced tumours, you can see that in fact this particular lymph node is very active on the PET scan, consistent with metastatic lymph node disease. So in fact here we are dealing with a stage 3C cervical cancer. With higher stage tumours, particularly stage 2B and above, the normal course of treatment will be external beam radiotherapy and chemotherapy, followed by brachytherapy. And if we have a look in the case here, we've actually included, for your interest, MRI in the context of brachytherapy. So just some tips with this. So typically what will occur is the patient will have an IDC within their bladder, and the idea here is to have a little bit of urine within the bladder. And they'll also have the applicator. So this monstrosity is inserted usually under general anaesthetic, and the tip of the brachytherapy applicator is ideally sitting within the uterine cavity, as you can see on this occasion. And in addition to that, you just be mindful that there's often associated vaginal packing. At our institution, they use a particular type of packing material, which if you're not familiar with it, can confuse you and make you think, oh my goodness, has the tumour expanded? No, this is just to try and hold the applicator in the right location. Now, often brachytherapy will occur after chemoradiotherapy. So by the time you see the first set of images for brachytherapy, you will see radiotherapy-related change in the marrow with fatty replacement. And often you will see a reduction in size of the tumour, and sometimes even very difficult to see the tumour. But in this instance, we can still see the primary carcinoma. It's not as large as it was on the original staging scan, but it is still present. And if we have a look at the broader aspects of the pelvis, we can see that abnormal lymph node that we identified both on the MRI and the PET is still abnormal. So this was her first set of brachytherapy. We would closely monitor her response during the therapy and give a post-treatment MRI assessment, usually between 6 to 8 weeks, depending on your local practice.